Okay, finally got the tech going.
Got the tech.
Oh, you're amazing. We do have some people that are coming in. I don't know where they're from. Hello, we've got Fleur, we've got Jessica, and we've got Dakota. They could be anywhere in Kimberley. They could be from Broome. They could be from Kununurra, Dirty or Fitzroy. So, welcome. I hope you can hear okay. So please speak nice and loud. Thanks, mate. I'm sure you will. And thank you for all getting up early and coming to our first morning minds, everybody. Very excited about this.
Thanks, Sarah. Morning, everyone. Welcome. Thanks for your patience with the technical difficulties to start. For those of you who don't know me, I am Luies. I'm a sport and exercise medicine physician. I'm a Gary Yarra man. Recently moved back home about 12 months ago to work full time as a sports physician here in Broome. I've trained mostly down in Perth, but also in Canberra here at the AIS. I'm here to talk about concussion this morning, and it's a pretty tough topic to condense something that's very complex into 60 minutes, or really 40 minutes, where I'm hoping we'll have some time for some questions at the end. And there's clearly lots of really tricky parts of concussion. If we knew more about it, we'd probably not have the state of affairs like we do with it. But I'm trying to simplify the best we can today. And I want to make obviously reference that this is some sport-related concussion, and that's sort of the domain that we sports physicians really work in. I try not to get too much into the sort of non-sport-related concussions, although they might be similar in sort of pathophysiology and how they occur. I find lots of ones, particularly the workers' comp ones, are a very grey area, and people really struggle with those. Normally I love questions, but given we're trying to fly through, let's try and save some questions until we get to the end, and hopefully we'll have time for them. These are some of the things that I'd like to touch on today. The why is concussion still relevant? Who's at risk? Bit about the pathophys. It's pretty dry, but I think it's good to sort of understand. And then how to assess and how to manage it. And then a bit about the return to learn and return to sport stuff that I think everyone in this room as a healthcare sort of professional really should have a good understanding of. And then what are some of our predictors of clinical recovery? Who are the patients that we're worried about with respect, and if they're going to have a really protracted recovery? Then I don't want to touch too much on CTE and acute cerebral edema because we actually don't know much about them, but they're the things that get sensationalised in the media, of course. So why is concussion still an issue in 2025? We still really struggle with evidence in this space. It's been really hard to get good quality evidence, specifically about return to sport with guidelines. But what we're ultimately aiming to do is we're trying to avoid short-term disruption to life activities. We're trying to minimise the risks of recurrent concussion, which is really important, and we're trying to protect against the impacts of long-term brain health. This is a really good principle, and those of you who are sort of in that rehab space, physios, sort of ex-phys and the like, we really know that all damaged tissues, whether it's muscle, bone, knee rehab, but the brain's exactly the same. It's a tissue that needs rehabilitation, and that's beyond the resolution of pain. Like the day after someone feels better from a concussion, like they still have a brain injury, even though they can't feel it, you can't see it. And I think that's the really tricky bit with concussion, is that you can't see the pathology a lot of the time. It's really subjective to what the patient often feels, and people really struggle with them. So we need a rehabilitation buffer, particularly in youth and community sports. Really what the focus of this talk is, not elite sports, but youth and community sport. And we need to be really cautious. We know that parents are concerned about long-term health of their children. We know that teachers and coaches are concerned about their duty of care. We know that sporting organisations and schools are also concerned about the health and well-being of athletes and students, and probably the legal implications of it as well. And governments are concerned about maintaining physical activity levels and ensuring a safe sport environment. So at every level, people are concerned about concussion. The scary thing is that 95% of all concussions occur in youth and community sport. all we hear about is in AFL, NRL, concussion. But most of it's occurring on the community sporting field, from kids all the way through to obviously adults. And the problem we have a massive workforce shortage. There will never be enough doctors alone to provide appropriate concussion care for the community sport. Which is quite a sobering and scary thought to think about. We are so well resourced in elite sport. I do work in an elite sport space in AFL, work in rugby union. Like, we have too many doctors. We've got concussion doctors. We've got someone who's there watching the video on game day. Here's a photo of the NRL bunker for those who are close leagueies. Literally, you've got people dedicated with Hawkeye cameras of 9 different views, watching every contact, impact, direct radio, direct communication down to doctors on the field. In rugby union, we've got an independent match day doctor who literally is there to make decisions around head impacts. We don't have that in this space. Who's at risk, really? We know that sort of children, youth, sort of under the age of 19, sort of the ones we're really concerned about, and that's due to that time of that neuroplastic change in brain development. Vulnerable brains are extra vulnerable to trauma. Females appear to be more prone to concussion as well, but the evidence is still a bit conflicting. But we certainly know they're prone to the prolonged recovery. And factors that can be associated with a complicated or prolonged recovery also include the previous history of being hospitalised with a head injury. Headache disorder or migraine, you can see how that gets pretty grave. Some of their symptoms might be headache related post-concussion, and there certainly exists post-traumatic migraines, which are sort of sitting in a bubble next to the concussion. Anyone with a learning disability or dyslexia, anyone with attention deficit disorder, or any other sort of mood, sort of anxiety or psychological disorder. So what is concussion? We know it's a type of traumatic brain injury. It's defined by the concussion in sport group as being induced by biomechanical forces. It typically results from impact to the head or the face or the neck. That being said, it can also occur from impacts anywhere on the body. Anything where there's a big sort of a decent enough collision which transmits force up through the neck into the brain can cause a concussion. The analogy I use with my patients is often like that the brain is like a sort of, the head is like a tissue box, right? So the outer sort of part of the box is your skull, and the tissues on the inside are the actual sort of brain. You can show them by when you give the tissue box a shake and the tissues kind of move in it. It's very akin to what happens with our brain when we actually get some trauma. We know there is a temporary impairment of neurological function. For some people, it can be super fleeting, seconds, like the old brain reset. It's a really complex injury and they're difficult to evaluate and manage. And what I really think is no two concussions present exactly the same. Everyone's concussion is a little bit different. We know they evolve over time and that symptoms can change within the first few hours and days of presentation. The good news is in most adults, symptoms generally resolve within 14 days following injury. I'm sorry about the slide advance for the intellects in the room, but from a pathophysiological point of view, we have a whole cascade of things that go on at a cellular level. We won't spend too long on it, but we know we get these biomechanical forces that cause cellular abnormalities. We see altered blood flow and metabolism, which affects the membrane permeability and causes increased neurotransmitter release and contributes to this neuroinflammation, as they coin it. We know we get neuronal disruption, sort of affecting the cell membrane, and we get some axonal stretching. We get ion channel changes where you get basically an ion flux, with calcium sort of leaving, calcium sort of coming in, causing sort of abnormal neuronal depolarization. Tend to get a lot of glutamate release due to this depolarization. We often see this energy demand change where there's an overactivity of these ATP-dependent ion pumps, which increases the glucose demand, which does lead to energy depletion of these sort of systems, and is thought to eventually be related to some of the fatigue that also people feel. The mitochondrial dysfunction that comes with that, also to do with calcium sort of rushing in, further exacerbates some of these energy supply issues. And we know we get oxidative stress due to the production of free radicals. So a whole host of this stuff is going on when we've had trauma to the brain. We know there's some sex differences in brain injury as well, as I've touched on before, but male and female brains have quite significant structural differences that affect the impact of these brain injuries. Females are at greater risk, and it's thought to be because the axons are smaller with fewer microtubules and are more susceptible to trauma under the identical forces. The role of imaging in concussion is quite sort of controversial. If you see someone in ED or someone's gone and they've had a CT head, you don't really expect to see anything on a CT head when you sort of do that acutely. You're kind of looking for the more serious traumatic brain injuries, the skull fractures, etc. when you're CTing someone's head. There are some very flash sort of images that are being used now, the MRS, which is magnetic resonance spectroscopy, functional MRIs, diffusion tensor imaging, cerebral blood flow measures, electrophysiology and PET scans have all been sort of tossed up as potential scans that can be used in concussion. Either in Broome, so, but either way, like there's an example of this is that the MRS can detect metabolic changes up to 30 days post-concussion. And we know that some of these things help guide some of the evidence that just because you feel okay at 3 days, there's a whole lot of stuff going on in the background that we can't actually see. We know you've got abnormal brain function during that time. Functional MRI shows altered brain activation up to 23 months post-injury. And there's changes in the white matter orientation seen up to 6 months after concussion. The problem we've got with these at the moment is there's no real good evidence base to work from. So they're not recommended for routine sort of clinical assessment at present. How do we sort of assess concussion? I've said it's quite a challenge. But it's really crucial for us to try and do our best to get that sort of diagnosis so we can appropriately manage and then prevent further injury associated with them. Diagnosis primarily relies on a clinical assessment of symptoms and signs. There is no specific diagnostic test that confirms or rules out concussion. There's a truckload of research going on at the moment. Everyone's racing to come up with some blood test, some saliva test, where they're going to be the first one to try to nail this. The person who does might be a very rich person, but at the moment, nothing exists. The thing we should all be referring to, and I've given you all a copy on your table, is the Sport Concussion Assessment Tool, as SATS. For all clinical assessments, it'll guide you through what to do. There is also a pediatric one, which is for those who are under the age of 13, D1 through 5 through 12, and you can modify one for pediatrics. That is really the thing we should be using, particularly those first-time presentations in ED. We're seeing these sort of patients. There's also, for the non-medical, it's one to talk to your friends, for kids playing sport, still playing sport. There is a concussion recognition tool 6 as well, which is freely available online. It aids non-medical individuals in recognising potential concussions as well. The other one I haven't included because it's like it's massive. It's even longer than the SCAT. The SCAT's pretty long. How many tables with this now? A lot. So the SCAT is the Sports Concussion Office Assessment Tool. It offers some more tools for diagnosis, goes into a few of the different domains. Concussions that persist for 3 days or more, the SCAT loses some of its validity. It's best really used in the first 72 hours. So that's where the SCOAT also exists. I reckon I'm pretty good at these. I'm bashing through all that. It's like a skill you do it a lot. You're good at it. I don't reckon I could get through a SCOAT in less than 50 minutes. That's long. Really long. Danger lanes a little bit here, and this is when we're thinking about someone in a sport-related environment now who's sustained a knock. These are some of the things that we really have to look out for as our sort of red flag or critical things we need to identify. Any individual who presents with neck pain, particularly with a suspicious mechanism of injury, increasing confusion, agitation, or irritability, repeated vomits. Very let footy players have one because they run and they drink a lot of fluid. So one is okay, but if it's a repeated vomiting, you get worried. Anyone who has a seizure or convulsion, any weakness or tingling, burning in the arms or legs, probably not thinking about concussion here, we're thinking about some other sort of neurological sort of trauma. Anyone who's got deteriorating GCS, unconscious state, any severe or increasing headache, unusual behaviour change or double vision. It's got really concussion there. We're really worried about serious structural brain injuries, serious cervical spine injuries, other neurological stuff, and that should have everyone's sort of alarm bells ringing if patients present with any of those. The obvious concussion one, and look, as much as I say I can want my life to be easy when I'm covering an AFL game, because it's really great sometimes with some of these guys who run 15 Ks in a game and tackle each other, to try and work out if they're concussed or not, because they're going to get impacts all the time. It's really easy for me when someone gets knocked out. We call these our criteria or category 1 signs. As soon as you are knocked out, it's concussion. Day's over, there's no grey, you're done. Even though I've had a few patients in the last 12 months who came in and said, I was knocked out, but I got up, I passed all my concussion tests and I was fine. Doesn't work like that. Like, you're knocked out, you are concussed. And I understand where some of it comes from, because sometimes you do get these guys who get knocked out, get their brain reset as such, and then they get back up and actually do feel fine. I agree that they tell me they feel fine. But that can exist, but that's the easy one. The other one is the fall. They get a hit and they fall towards the fall. What do we all do when we actually fall? We put our arms out to break our fall. Watch enough footy, live, you'll see it. People get sort of hit and they fall with their arms by their sides. They don't put their arms out to break their fall. Another one, again, they're easy when they're like that. Anyone with seizure or jerky movements post-impact, you see that every now and then. Someone is sort of having myoclonic sort of type movements on the floor. The other one is they're sort of, decerebral posturing, their arms stuck up in the air, stick out in front. They're easy when they do that. Confusion, disorientation is a bit harder. We run out, when doctors run out to check players on the field. I've got a little battery of questions. We're trying to screen all those players, what they're doing, where are we today? And if they tell me they're in the wrong place, well, get it later, you're done. I've noticed that some of my players have taken to writing the answers to their questions on their wrist. They practice with one another. I see it before the game. Yeah, we're at the stadium. It's Saturday the 14th. Yeah, we played this person last week. So for guys who are supposedly trying to help me do my job, it's tricky. Memory impairment, that fits into that same one. So one of the initial questions we often ask is, who are we playing now? Obviously today, but who did we play last week? Right, so it goes, you actually make them work out who they played in their last game. Did they win or they lose? The unsteadiness is another good one. And I see coaches now training this as well, which I hate. Someone gets knocked and the coach will tell them, when you get up, just take a knee for a bit. Because if they get up and they wobble, or they're unsteady or they're ataxic, they're done. Any new or progressive symptoms reported by athlete, you'll see in SCAT, there's a symptom sort of page, there's a whole lot, 22 different symptoms, any of those sort of things across multiple domains. Report all the day's appearance with blank vacant stare. I find that a bit tricky, but they're often our sort of symptoms. They're easy, and we don't need to take them off for a scat during a game if people have any of those. It's immediate concussion. The scat doesn't help us now. We can do one later to see what your symptoms are, but I don't need to do one of those in a game. This is where it starts to get tricky when you start getting more of these subtle signs. A bit of change in behaviour. They're a little bit more agitated. They're a little bit anxious. They're a little bit more emotional. Headache, right? Everyone thinks about headache as a concussion sort of symptom. I think it's one that we see fairly sort of often, but you don't need to have a headache to have a concussion. People describe pressure sensation in the head, nausea and vomiting, the dizziness, blurred vision, balance issues. These are all subjective sort of things that, that sometimes they will tell you, or you kind of like, oh, did he stumble? I mean, he's just run literally up and down the field repeatedly for 10 minutes, like and been tackled and chased. So it's really hard to say sometimes. But these other ones, feeling slowed down or in a fog, I just don't feel right. Typically concentrating on remembering, people who are not remembering basic game plans or usual sort of things, or you often see ones where players will go the other team's huddle as well, like every now and then to watch that footy. These are all busy signs. We're not so subtle with that one. Of things that something's not right, but then the fatigue and low energy, feeling drowsy, again, heightened emotion, sadness, nervous with anxiety, or probably so basically anything represents a concussion, right? And we have to be aware that it can be, something as subtle as these things. And I think the tricky thing with often when we're trying to pick these things, people can have these symptoms as part of their baseline. Right? They've got, anxiety, or they've got stuff. I've been feeling fatigue for 3 months. It can be really hard to tease some of that stuff out. Quickly talking about the minimal removal for criteria removal in sport. And this is where we're trying to think about community and youth sport now at the moment. But any sort of athlete or individual suspected of having a concussion must be immediately removed from play. It's not removed at the end of the quarter, it's immediate removal. And if we're, like I said, this is the slogan they came up with. If in doubt, sit them out. We need to pull these individuals out of the game. They need to have a medical assessment done, and they need to be continuously monitored for any signs of deterioration. They are not to return same day. Talk more about when they can return, but absolutely, it's not I got knocked out, cool. Next quarter. There's none of that. They must have a comprehensive assessment, evaluating for loss of consciousness, symptoms, cognitive impairments, neurobehavioral symptoms, and their balance issues. That needs to be done. That's what an assessment of concussion needs to include. And any abnormality across any of those domains could represent a concussion. And use the stat. So what do we do when we think we see one? Go back to our classic first aid principles, the ABCDE. So assess their airway, make sure they're breathing, make sure they have a circulation issue. The disability, obviously, we can start asking some questions about, we think they're alert or confused, or GCS for those who use that. The next big one, we know that if someone has had a concussion, we can't trust them to tell us that their neck is okay. That is why they are removed from the ground with C-spine precautions. So we need to use a manual inline stabilization, the mills as they call it, which is to keep that neck midline, which is what you see if you watch a bit of footy sort of on the telly of people being removed, like after they've been knocked out with C-spine precautions for that reason. Clearing a neck on a football field, probably not an advisable thing to do. You're braver than I am. We need to review the mechanism of the injury, sort of what happened. Witness accounts are really important for obvious reasons. We need to go to the signs of the symptoms, and we need to do the cognitive and neurological status, including balance. Again, use the stat. Certain people, and again, not really in community stuff, but we sometimes have computerized neurocognitive testing where people go through and they have a baseline score as normative data, which we can compare them to, often at pre-season. The other one is medical imaging is reserved for any of those red flag types of things that we talked about a few slides ago. We think someone's got a skull fracture, we think someone's got intracranial bleeding, we think someone's got a C-spine injury. said before, there are no serum biomarkers that are helpful here. Don't be doing bloods thinking you're helping you make a diagnosis. Do them for other reasons. This one I think is really interesting, the delayed case, because how many of us actually use concussions in Australia? Probably not many. And the reality is most people who come and see any of you will be a delayed case. So if an athlete or individual presents during the week with potential concussion from the weekend, your job is to assume that a concussion has occurred. And there is no definitive test. It's not, I go to the doctor and they conclusively sort of said I didn't have a concussion. It's what people want, right? Rock up on either Monday or Tuesday, hey, and I had this happen on the weekend, I'm going to walk with that, can you clear me a plate on the weekend? Doesn't go like that. I think I gave you a copy of this one. Okay. This is just a little sort of algorithm, you know, for the healthcare practitioner who sees the off-field days after the incident type person come in with an initial concussion decision tree. Usually they come to you because they've got a suspected concussion, you know, a lot of the things that we've obviously talked about in the history, the loss of consciousness, etc., and you ask if they've got any of those, right? And then if they do, again, makes it easy. You sort of go down this pathway where you go into do your scatter, you just go out 6 if they're after 72 hours, do a neuro exam on everyone. If they're sort of abnormal, you know, and then you've ruled out, you know, intracranial pathology or spinal injuries, you go into a sort of standardized graded return to play concussion management, which we'll touch on in a little bit. Lots of the things sort of get us to get to the same sort of point. Your job is to obviously exclude those intracranial and spinal pathologies, or nah, maybe they're okay, they didn't have any of this, you know, you've done a scat, and there is some normative data that I can share with you if you're someone who is likely to see these, because in our sort of elite sport world, we've got baseline tests on everyone, so we know what they have something to compare it to. The problem is when you don't have a lot of concussion history, or you're a community sort of sports person or a child, you don't have any normative data a lot of the time on what your sort of what numbers on your scat indicate whether you've got concussion, which is hard. But if someone's continually reporting symptoms, right, it doesn't matter what their balance score is if they've got symptoms at the same time. Anyway, that's one for reference. I've already kind of screwed this a little bit, but you know, this is the thing. You should have copies of this. There should be copies in ED. There should be copies in your practice, and use this. They're really handy to be able to give the patient to take with them, particularly if they're going to be seen by a colleague of yours further down the line through an ED. You know they're going to need some follow up with a general practitioner or other health person. Give them a copy of their scores, because some serial scats are really effective as we watch those symptoms sort of improve over time, watch their imbalance improve over time, watch their sort of memory improve over time. Really valuable to be able to share that data with your colleagues who you're sharing management with. These are some of the other things that I tend to obviously do as well. I don't get many acute staff. My books are too sort of round at the moment in Broome. You know, I never see it sort of more acute than 6 weeks. But you know, if someone was to sneak into me and get sort of acutely, I would always do obviously a really good C-spine exam, which includes range of movement, palpation, you know, strength, and other sensory motor testing. I do vestibular and ocular motor testing. Right? There's a very nice sort of screening tool, which I'll touch on in a minute, called the BOMS test. Right? And any of those, and again, don't do it within the first 72 hours. After 72 hours, you can do a BOMS test, which tries to highlight, is there any vestibular ocular dysfunction? And autonomic testing, I don't think anyone's going to be able to do this very unfortunately, but you know, some people have autonomic dysfunction with heart rate, blood pressure, sort of dysregulation, post-concussion, and normally we'll stick them on a buffalo, do what's called a buffalo treadmill test, but they get on a treadmill and we watch what their heart rate does as we increase sort of intensity. Real specialist level stuff. This
kind of like
similar, watching what they do from an autonomic perspective when we gradually increase exercise and bring on symptoms with usually abnormalities in there. sort of hemodynamic status. Concussions, we talked about before, can affect symptoms in a broad range of domains. And what we're really trying to do with our patients who are trying to manage them is try to work out, have they got more physical symptoms, which are autonomic, sort of neck, cervical, vestibular, ocular, and neurological? Are they more that cognitive sort of symptom? I can't remember, I can't concentrate, can't do my schoolwork when I read, do things like exacerbation of my symptoms. The emotional sort of domain where mood and anxiety symptoms and behavioural things are a bigger issue. The fatigue, I'm just so tired and fatigued with everything I do. And then the sleep dysfunction. So we're trying to see which cluster these patients fit into. And the really bad ones have symptoms across all different domains. Got a really sort of horrible slide in a minute, which shows you how they all cross over. This is a BOMS test. Did I give you this one?
Yeah.
I did. This is the AIS version of it. The idea behind a BOMS test, it's a screening test. It's not diagnostic, but what you will do in a BOMS test, you ask a patient baseline, sitting in front of you before you harass their sort of vestibular system. You get a headache at baseline out of 10. You get their nausea out of sort of 10. You get a dizziness score out of 10. And then you get a fogginess score out of 10. Then you go through and you challenge smooth pursuits to start with. So challenge their vestibular system and see if their symptoms increase. I had a little bit of a headache, then you made me follow your finger, and now I feel headache's worse. I feel terribly sort of dizzy and not sick. Probably have the vestibular sort of component to their symptoms. All right, go through the saccades. Tend to never do convergence because I can never actually, watch it come in and work out when they're actually not accommodating anymore. But even if you're getting some of this done, like smooth pursuits, the saccades, the vestibular ocular reflex, like at least some of it, it kind of gives you an idea, hey, there's some vestibular ocular dysfunction here. This individual is probably going to need some vestibular ocular rehabilitation as part of their sort of recovery. This is sort of the complex stuff, right? A lot of concussions will get better without this stuff, but for the tougher ones, like it's good to know that these, exist. This is the sort of the important stuff that you give. This is that initial sort of acute advice. We've made a concussion diagnosis. What are we going to do? Simple stuff. We make sure they go home or they're with the company of a supervised and sensible adult. They're not allowed to drive. You don't clear them to drive if they have any of those symptoms where their brain is not functioning normally. We don't let them drink alcohol, obviously. We review medications, and the ones that they say we should particularly look into, are they on any aspirin? Theoretically increase your bleeding risk in the context of head trauma.
Is that theoretically? Because a lot of people, we give them all general Nurofen at triage. Girls have never seen any issue with
look, I think your risk level is probably low there, line, but the powers that be put together these illustrious guidelines suggest that there's a theoretical risk there. Half of the board I know play on anti-inflammatories anyway. That's true. I haven't seen anyone go, oh, they've had a big sort of bleed because of it. So I agree. I think that one's probably a bit grey, but the guidelines say ask them about, I really think the bigger one though is probably sleeping tablets and sedatives. Any CNS depressant, which may mask or worsen their symptoms, is probably not the way to go. The first and initial management strategy for all of these patients with concussion, they need physical and cognitive rest for the first 24, 48 hours. There's no work, there's no going down to play, a light or play lightly, it's not a lot of screen time. They really need to take it easy, from school, away from school or work for at least 24 to 48 hours to start with. From then, we want a gradual resumption of activity after 24 to 48 hours. Beginning with some light to moderate intensity physical activity as well, as long as our symptoms don't worsen as we go to sort of increase our heart rate a little bit. Majority of people, it's about 90% of people, recover in 10 to 14 days. It's really only 10% that have these lingering symptoms. Keeping people away, I've certainly been guilty of this in the past with people who have really high symptom burdens, but keeping people away has actually been shown to be detrimental long term as well. So we need to make accommodations for these patients. I'm sorry about this slide. It's like very small. This is trying to show you the different domains of concussion. We talked a bit about the vestibulocular, the cognitive stuff, the fatigue, and anxiety, mood, and headache, migraine. But as you can see, they can all cross over. The point of this is trying to show you can have symptoms of multiple domains at once. And really what I'm going to share this, I think I'll read it afterwards, but it shows us that different sort of domains kind of need some targeted rehab and management in those areas. Vestibulocular stuff needs some vestibular rehabilitation from a vestibular trained physio, and then a graded exposure to stimuli, things that challenge that. The ocular stuff is they need some ocular rehabilitation, which crosses over with that vestibulocular stuff. And often they need some lens changes with their eyes, so we use neurooptometry. The headache and migraine stuff, they often usually do really well with some manual therapy sometimes. Neck and treatment of the headache is sort of might be concurrent. There's lots of those. The anxiety and mood stuff. I don't know if you can read it, but the main one it says maintain social engagement. The people who you take away from everything, don't let go to school, don't let go to work, they sit at home with all their symptoms, they do terribly. It's really important that we keep them engaged in their team, in their school, in their work. Help them out with mental health, counsellor, a psychologist, some CBT is really effective there. Fatigue ones are also a bit tricky. Again, CBT sort of recommended, graded exertional tolerance of building stuff up. In the chronic setting, they're really hard, but they're predominantly fatigue, using some pacing strategies. And then the cognitive stuff, they need academic or work modifications, more breaks, more time to do their work, shorter days to start with, and then you get some formal neurocognitive evaluation from a neuropsych if that's where their predominant stuff is. This is not we can't go into all this today, but this is just a brief look at some of the things that some of these patients need. Really trying to crack along here. Children, right? We know that they're really common, obviously, in kids. We have to be more conservative in this age group, right? We know they have slower recovery from their concussions. We know that there's significant developmental differences, with physical, cognitive, and emotional differences at younger ages. We know that they've sort of got increased vulnerability due to both biological and anatomical sort of factors and alterations in cerebral function, right? The kids who are trying to push them along aggressively, it's not the way to go. We've really got to be slow with the kids, these ones. This is the rest slide, right? So this is all youth and community sport. Doesn't matter, kids or adults, they need this rest period, We know at the same time that prolonged physical and cognitive rest is detrimental. I've certainly been guilty of this in the past for years where I've decided I just can't get this guy doing anything because they're just blowing his symptoms up too much. Like lots of schools are a lot better with it now. Haven't seen how the Broome schools go or anything like that, but keeping people away, they do worse. We're really better off getting them back integrated with modifications rather than isolating them away from anything social, anything violence. But, the relative rest of 24 hours is pretty mandatory. We're trying to get them to their normal activities of daily living, but no significant physical exertion. And that's not for the kids to go and sit on their PlayStations and, spend a whole day at home doing that as well. The return to sport stuff sort of goes like this. We know beyond that 24, 48 hours, lots of people are starting to feel better. We want to gradually increase cognitive and physical activity, where majority of students have actually returned to learn. So RTO has returned to learn, so it's getting them back to school by day 10, right? We really want to get them back quickly. pause this for a second, but the return to learn takes priority over return to sport. Everyone's focusing on, yeah, I need to get back to footy, I need to get back to that, I need to get back to that. Our priority really needs to be, no, let's get you back to school first. Let's get you back to work. Let's get you back to your studies. That is the priority first, and the sport stuff can follow. The new guidelines, and this is probably the one take-home thing from today, is that the minimum time you can return to contact sport from a concussion is now 21 days. Last year, when they brought out the new guidelines. It's a long time. People in the community do not like this. The other caveat to that is, and that's if all goes well, that is, I've had symptoms for 24 to 48 hours, but they also have to have been symptom-free for 14 days first. If your symptoms drag on for a week and a bit, your 14 days doesn't start until your symptoms technically start. And it's going to be longer than 21 days. You can see why people don't always tell us the truth about their symptoms when the earliest you can return now is 3 weeks when you diagnose a concussion.
But I presume this isn't diagnosed done by a health professional.
A health professional.
Because when you go to Perth, they're all 20 pool, 20 have their own little dad or mom who is paramedic. It's nothing. It's just the medic, and they're happy to call everybody concussion. And you're like, I didn't even see the head up here. But anyway, and then and I think that's where the problem comes from. There's a lot of they just overcall it, just like any 13-year-old. They come off the field and they're already talking about arthroscopies, and 5 minutes later they want to go back in the field because the knee is not sore anymore.
Does happen like that, but I guess what we're also going with here, we're just seeing the kid stuff. They've got a vulnerable brain anyway. We're trying to be conservative. And we're going to we're not probably going to have everyone all on the same page here. You know, people are not going to like this. But the reality is with the stuff we now know where it's at, like if you make a diagnosis with a healthcare practitioner, like patients need to stick to this, and I'll show you something in a minute that can help you with that. Quickly touching on return to learn, we know that it's about facilitating a graduated return of those to regular school routines. Again, it takes precedence over return to sport. We need to give them more frequent breaks, extended rest periods, additional time to complete any of their work or tasks. And it's really our job as healthcare practitioners to communicate this to schools and workplaces overall. There is actually a nice little place for return to learn campaign, right? It's actually a nice way to use to build it out and send it along to school, sort of with the kid, and the schools sort of role is to accommodate it. We talked a little about that 14, 21 days, and where people get really pissed off is that elite sport is not the same. Oh yeah, but the footy players go back at, much quicker. They go back in sort of 2 weeks. And I understand why the sort of, there's, people are upset about that, but the reality is elite sport guidelines are completely different. We have sort of multiple resources to look after these, and it's not that, a elite sport brain heals quicker. There's lots of political stuff that goes on with these conversations, but they have obviously baseline data, to compare from the scat and neurocognitive testing. So we kind of probably diagnose them more accurately. There's sideline care and all contact stuff with doctors. We have video recording, so we don't really miss these things. We have access to clinical management teams with multiple people, to manage these sort of things. We just don't have the resources for that in the community, which is why some of the differences exist. But yeah, I also am aware of how the optics of it is that, elite sport goes this fast and community sport goes that fast. This is a kind of example of how you would approach a community sort of person wanting to return to sport. They have their incident that it was recognised concussion appropriately. They were removed from play. They've done their rest for 24, 48 hours. They're assessed by a healthcare practitioner early, which sometimes also is tricky in Broome. And then they've obviously been talked through, what they're going to do, resuming ADLs, go into some life aerobic exercise with some modified learning, on the first day. They're allowed to do some skill stuff and training, obviously with enough control coach buy-in, without moving their head a great deal, progress to some moderate walk, stationary bike, etc. And then some sports skills movement. These stages, guys, are all 24 hours at a time. You can't go, well, I did this, and this on, first day back. That means your first day is you try and get through your ADLs and see how you're going. As long as you don't have significant symptom provocation, you wake up, yeah, it wasn't too bad. You can then go to the next stage. All right. If you are struggling to progress without significant symptom provocation, you don't progress through the algorithm. You are supposed to have a checkpoint. And this is where I think Broome is pretty tricky, but you're supposed to have a checkpoint no earlier than day 6 with a healthcare practitioner to check how you're going. And if you get a bit of a sign off, yeah, you're going pretty well, theoretically you're allowed to add in some resistance training, get in the gym or something then. And again, each 24 hours is adding intensity and complexity of review needs. But the goal is we want to get back to full capacity work or learning and exercise activities before we then have a second checkpoint. And we're supposed to have been 14 days symptom free now, before we then get cleared by a medical or other healthcare practitioner. And really, they want a medical person at this point to say, hey, you're all right for contact. And you don't go into, this isn't a game, this is full contact training. And you're supposed to do some competitive simulation, have another checkpoint, I've been tackled, I've been bumped, I feel okay, and then go back through again. It's pretty complex to be able to coordinate all that. That's why we need lots of coach buy-in, and we're going to do a community session soon, because we really need the coaches here to be able to help that. This is the same thing, that said in a different way. You can read that and have you a copy of that one too. Same thing, different view of it. But again, it really highlights that everything has to go perfect for them to return at week 3. I would certainly look up and download this one. This is where all this information comes from as a joint sort of document, the Concussion and Brain Health Position Statement 2024 that was put together. So last year, it talks about all of this: concussion para-athletes, female athletes, workforce issues, how to do stuff, long-term brain health, etc., etc. It's a really great resource to pass all this on. Really quickly, as we sort of wrap this up, there are concussion referral and clearance forms that I really think would be a good thing for us all to sort of implement. I don't know if I gave you one of those. Did I? No. But they basically are a way that you can again have them in ED where you diagnose a concussion, what their symptoms were, and then it plans for obviously the initial consultation. It talks about the grade and return stuff, and then the final stage is, as a healthcare practitioner, we are happy that you've reviewed the first section of the form. We are happy that the person has been symptom-free for 14 days. They will not return to competitive contact in less than 21 days from the time of concussion and completed a graded return to sport. And that's to stop those people who go back. I was not there on the weekend, but I'm playing for you next weekend. Hard to implement, but I think the medico-legal risk here as well for all of us is also sort of not insignificant. What's the risk of returning too early? We know that if someone goes back to sport with a concussion too early, increased symptoms of duration and a real delay in return to baseline. The secondary impact syndrome, which is the one that people have ever had, unfortunately died from, someone who had a concussion or a head going in sport and they died. It can be this where you get it's very rare, but it's a fatal sort of brain swelling in the second concussion occurs before there's full recovery. We don't know much about it, but it gets obviously sensationalized in the news. Cognitive impairments, we can get memory, attention, decision-making deficits, ongoing sort of emotional and physiological effects, balance issues. I think the reduced performance one is a really good one to highlight, that we know they've got reduced reaction time and processing speed. And sometimes that's the way that I sell it to people, that they're letting their team down if they were going to go back and they're not going to play as they normally would. We know, we're not sure why, but the concussion threshold seems to decrease with multiple sort of head knocks. And what that means is the initial amount of force that might have been required for that person to first experience a concussion tends to lower with the more head knocks they get. We're not really sure why, but you know, it becomes far easier for some individuals to end up getting a concussion, you know, where they end up with almost trivial knocks that they wouldn't have actually had a concussion from previously, and now causing sort of concussions. The long-term brain health stuff is always what we want to talk about. Am I going to get dementia? You know, that's really that CTE, which is the chronic traumatic encephalopathy. The one that I think is not talked about enough is the musculoskeletal injury risks. I didn't put the stats in, but we know that people who go out to play when they're still concussed have got a significant risk of soft tissue injuries and joint instability, and not sort of, you know, benign joint instability. People tearing ACLs, right? We know that these people have altered neuromuscular control. They make bad decisions. They put themselves into positions that they might not normally do if their brain was working well. The real risk is we let someone back out and then they go and they tear an ACL, they sustain another significant musculoskeletal injury, which are very real, and they can have a real sort of life-altering sort of way they approach exercise. These are some of the, you know, risks of prolonged recovery. And these are probably the ones where you go like, if you're seeing any of these, you're like you've got a load of severity and number of concussion symptoms. And that scan you initially do, there's 22 different symptoms. It's a total score of 132. So someone who's ticking symptoms in 22 boxes with, you know, high symptom sort of burden, they're probably the ones who are going to take a long time, right? If you've got a prolonged loss of consciousness, you get knocked out for more than a minute, I've never seen one of them recover quickly. A seizure, you know, after being sort of hit, there's previous history of concussions. Everyone with a PE, all meet those people with history of multiple concussions. They take a long time. You know, young people, are females, as we touched on today, and also those people who've got sort of psychological stuff and migraines. They do take a while. And they're probably good ones to flag early and consider referral, you know, early to someone for specialist management. The multiple concussions one is always one that comes up. How long should someone take off? And it used to be really airy about what the answer was. So the concussion sport guidelines now have made what is a multiple concussion? It's 2 concussions within a 3-month period, or 3 concussions within a 12-month period. These require an extra conservative approach. And the management team, you know, really should be someone with some concussion expertise. These are tricky. While no fixed return to sport timeframes exist, what the guidelines are now recommending is that if you have your 2nd concussion in 3 months, you must be 28 days symptom-free, and you're not allowed to return before 6 weeks, is the recommendation. If you have your 3rd one in 12 months, the advice we give now is you consider missing an entire season of that contact sport.
So is this for elite and community?
Pretty similar, even for the elite stuff. It's a long time. That's what they're basing on now.
Let's say they have 2 seasons, or like 1 season with 2, and 1 season with 2.
Yeah.
Is that when you recommend retiring?
Yeah, look, any recommendation to retire from sport is never one individual's choice. It's usually managed by multiple people. We usually get a neurologist with input in it.
In like
That
20
point.
years.
Yeah, that'd be a hard one. It gets hard and it's very giving people good advice that's actually based on evidence is quite tricky. Last couple, chronic traumatic encephalopathy. Everyone likes to talk about this. Most of you may have seen that movie Concussion, which talks about this. Like, it is a neurodegenerative pathology linked to history of repetitive head trauma. It's only confirmed through post-mortem. Nobody can diagnose this while someone is alive as yet, right? It's only done through this post-mortem. And we know what they get is they get tau accumulations in the brain. They look like that when you cut them open, but we don't even have imaging, and those are the things that can actually diagnose this at the moment. The scary thing about this is that people think that everyone who has a head knock during footy at some point thinks they have CTE. I've seen lots of people with CTE, but you don't have CTE. You're a middle-aged man who might have depression or anxiety or some other diagnosis. And everyone wants to always attribute it to the footy or the head knock, not potentially the drinking and drug use, other sort of mental health sort of things. You know, and that at the moment, the evidence really doesn't connect and they're possibly linked. But I don't think we should be, you know, listening to these sensationalist sort of stories that go, head contact is inevitable that you end up with CTE, because that's clearly not what the evidence shows. We certainly need more sort of research, you know, good studies that confound for all those variables. And I feel really sad because I see the ones in the news have been AFL players who've lost their lives. All right. The biggest killer of sort of men, you know, post-footy career often is men themselves from, you know, mental health stuff, depression. There are a lot of drug and sort of alcohol problems, unfortunately, in that playing cohort as well. A lot of other risky male behaviour that comes with that. One of the guys went and became a boxer after his footy career. And then the family blamed footy. And known to have a, you know, drug and alcohol substance issues in the past. It's really hard to point your finger at that when you've got those confounders. We need good studies. Acute cerebral edema is the other one. This is where people sort of die. You know, we know that it's rapid brain swelling, following a second concussive injury. We know that using animal models only, they've indicated there's vulnerability period post-injury, which second impact can cause severe external damage associated with chain dysfunction. So it makes sense, but why does everyone not get this? Who gets it? We don't really know. It's because it's so rare, no one's really studied it particularly well. It's like most things, we need more research. I think this is a really big one because everyone's kind of slammed contact sport, you know, and non-contact sport, netball, basketball too. You know, oh, I'm so worried about concussion, I'm so worried about concussion. Australia's got an obesity epidemic. Individuals who are obese children are at risk of poor brain health in midlife as well. Australian adolescents and young adults have high rates of poor mental health. And they're dropping out of organised sport at an alarming rate. Sport provides so many physical, psychological, emotional, and social sort of benefits for young people and adults. Some schools now are taking decisions where they don't even have team sports because they're too worried about the concussion stuff, oh, we're going to get sued. Like, are we having a net negative result by being too crazy with the concussion stuff? Almost certainly. The take-home message for today is we've bashed through a lot. If you take nothing else other than it needs to be 21 days for both youth and community, doesn't matter whether you're, you know, a 15-year-old footy player, doesn't matter whether you're a, you know, a 40-year-old amateur netballer, like 21 days from the time of concussion until you return to a competitive contact environment, and no return to contact repetition training until symptom-free for 14 days. Use your resources, use the SCAT, use your return, give patients that if they need to. We're trying to make a simple approach to a condition that's about simple. Thanks for your time this morning.
Thank you very much. So thanks to Nathan because he's given up his time for this this peer-led education series that we're doing. All our health professionals are doing it off their own back with their passion. So thank you very much, Nathan, for that. I actually have to run off and teach some old people. That's fast. I love them. If you haven't signed in, please do. Our next session is about renal and kidney health in the Kimberley. And our next one after that is going to be critical discussions, how to talk to people and tell them to go stuff, or have a conflict resolution with somebody. So that will be really interesting.
Yeah, that's
Thank you very much for coming. Now, on to what?
Thank you again for this.
Okay.
Do you need their needs and stuff like that? Do you need them to come? I mean, they're only going to be here for a couple of weeks at least. Do you need them to